Welcome back to the Health Longevity Secrets Show with Dr. Robert Lufkin. Our guest today is an expert in treating people with heart disease on the operating table, who has now begun to treat patients before they have a heart attack and arrive on his table. 88% of Americans are metabolically unhealthy. Let's find out what needs to change to lower that number. Dr. Philip Ovadia is a cardiothoracic surgeon who also has a practice focused on metabolic health and reducing cardiac risk. He completed a residency in general surgery at the University of Medicine and Dentistry at New Jersey and a fellowship in cardiothoracic surgery at Tufts, New England Medical School. Before I begin, I would also like to mention that this show is separate from my teaching and research roles at the medical school with which I am currently associated. It is part of my continuing effort to bring quality, evidence-based information about health and longevity to the general public. Now, please enjoy this interview with Dr. Philip Ovadia. Phil, welcome to the show.
Thanks, Bob, for having me on. Excited to be here.
I'm so glad you're on the show. I'm excited to. I can't wait for your new podcast to start. That's going to be coming out right about the time this show is, and also your new book is dropping in November. I think it's got a great title. Stay Off My Operating Table. I love it.
Yeah, I'm really excited to be able to, connect with the larger audience with both of those, and I think a lot of people in your audience will find it informative and useful as well.
Yeah, you have a unique position in this space in that you are an expert cardiothoracic surgeon practicing, who now has also chosen to, rather than treat people on your table, give them the tools so that they can learn how to prevent and avoid cardiac disease and hopefully not wind up on that operating table.
Yeah, exactly. I think both my personal and professional sort of journey has led me to this point, that I've really come to appreciate that preventing these health problems is a much better strategy than treating them. And as much as we've made advances and gotten better at treating all these conditions, with whether it be pharmaceutical interventions or surgical interventions, we still have not gotten to the point that preventing the disease in the first place isn't better than treating the disease.
Yeah, I would love to hear more about that, about your story for our listeners, because it's very compelling. I think you and I share a similar background, not only that we're both medical doctors, but I think growing up, my mom was a dietitian. And so she religiously followed the USDA guidelines, and we ate margarine, diet soda, low-fat milk, and avoided sugary cereals. And, anyway, but yeah, tell us how you got involved in this interesting space.
Yeah, so as you said, a very similar background. I grew up in a household, with both my parents were obese. I had a brother who was a type 1 diabetic. From a young age. So, we were certainly very mindful. My parents were very mindful about what we were eating. And as you said, it was right in line with the US dietary guidelines. It was, low fat everything. It was, but it was margarine instead of butter, and it was skim milk. And we had no sugary cereals. We had all the, what we were told were the healthy Cheerios and Wheaties and all the wheat-based products. And despite that, and I was a very active child. I played sports year round. I, rode my bike everywhere. I walked to school often. And despite all that, I just, was obese as a child, and it continued to worsen. And I went through college and medical school, and, just got, heavier and heavier. And, I tried many things along the way. I did all the things, the extent of what we learn in medical school around weight loss, which is, eat less, move more, and eat a low-fat diet and count calories. And I did all of that. And at times I would have successes and lose weight. But as I think a lot of people, experience, I would then gain back the weight and usually more. And I found myself about 5 years ago as a morbidly obese, pre-diabetic cardiac surgeon. And I realized that, I was going to end up on my own operating table if I didn't, do something. But again, I was kind of at a loss as to what to do. And I was very fortunate, through a series of events that first started with my wife. She had our two daughters at that point and was struggling with heartburn. And one of her practitioners suggested that she try eliminating gluten from her diet to help with the heartburn. And honestly, I was skeptical at first, kind of mainstream cardiac surgeon. And I said, well, you don't have celiac disease. What does gluten have to do with any of this? But I am a very supportive husband. So I'll give it a try with you. And we did that. And I noticed right away, I felt a lot better. I had more energy. I wasn't getting tired in the afternoon. And I started to lose a little bit of weight. And honestly, it still didn't really click. And then a few months later, Gary Taubes was the guest speaker at one of the medical meetings I was attending. And he had just written The Case Against Sugar. And, he was really the first. It was the first time I heard about low carb, low sugar, and its influence on health and specifically on weight. I, immediately, on the plane ride home and within a couple of days had read, all of his books, Good Calories, Bad Calories, and Why We Get Fat. And immediately, at this time started doing low carb, sort of intentionally. I realized in retrospect by going gluten-free, I had been doing lowish carb unintentionally, but so I lost a bunch of weight. I started to feel a lot better. And then I started to ask the questions of why didn't I hear about this before? I spent my whole career, treating the end product of obesity and poor metabolic health. I myself had gone through the struggle, and I had never heard this information, about, low carb and getting into the whole, sort of alternative ideas around weight loss and metabolic health. And as I asked more and more of those questions and got deeper into it, it obviously has led me to discover a lot more information about how important metabolic health is to our overall health. And so now I've kind of, although I continue to work as a cardiac surgeon, I have an additional focus, a new, kind of passion in helping people prevent heart disease and prevent chronic disease rather than having to operate on them, to treat their heart disease.
So for heart disease, how does your thinking differ from sort of conventional teachings in the medical profession that so many of our colleagues are following now?
Yeah, as and I'm sure most of your audience knows, the traditional thinking around heart disease, or I shouldn't say the traditional, the recent thinking around heart disease is that cholesterol, specifically LDL cholesterol, is essentially the causative factor behind heart disease. And therefore, if we can lower people's LDL cholesterols, we're going to prevent them from getting heart disease. And this has been the prevailing hypothesis, basically, since the late 1980s, early 1990s, corresponding to the release of statins and other medications that were targeting the lowering of LDL cholesterol. And honestly, again, I'm sort of a big picture guy, simple concepts. I look all around me and I see that it is not working. I continue to be a very busy cardiac surgeon, and at least half, and actually some of the data suggests up to 75% of the patients that end up needing cardiac surgery have a low or normal LDL cholesterol level. Some of that because they're on medications already, some of them just because, their diet and their genetics and whatever else it is, keeps their LDL cholesterol low. And yet they're still showing up on my operating room table to have heart surgery. And, again, I went through the first 10 plus years of my career as a cardiac surgeon and never really thought about that. But now I kind of kick myself and say, how did I not think about that? So, LDL cholesterol, just by that sort of fact alone, cannot be the causative factor. It may play a role in the process, but obviously there's got to be something else that's driving the epidemic of heart disease. And when you really look at the data and you look at the literature, it becomes obvious that metabolic health is, the root of, or poor metabolic health is at the root of heart disease and much of the other chronic disease that, plagues our country, our world currently. And again, when you look at the data that's out there, and this shouldn't be controversial at all, but it is, the amount of risk for heart disease that's predicted by LDL cholesterol alone is very low. We're talking about a 1.3, 1.4x, for someone with a high LDL cholesterol as opposed to a normal LDL cholesterol. When you look at the risk associated with poor metabolic health, that risk is on the order of 6 to 7x. So it's much more powerful predictor than LDL cholesterol is alone. And so then you have to step back and you say, why do we focus so much on LDL cholesterol? And honestly, the only answer that makes any sense is because we have a medication that treats LDL cholesterol. We don't have a medication that treats poor metabolic health.
If we don't follow the LDLs, or if it is secondary in importance, what about triglycerides and HDLs in the lipid panel?
So again, the data around that is pretty straightforward. Both HDL cholesterol being low and triglycerides being high are much more predictive of the risk of heart disease than LDL cholesterol being high. For me, triglycerides and HDL, specifically the ratio between your triglycerides and your HDL, is a very good predictor of metabolic health. And so that makes a lot of sense. And in fact, we'll get into how do we define metabolic health, but the official definition of metabolic syndrome, there are 5 measurements that are looked at to determine if someone has metabolic syndrome, and HDL cholesterol and triglycerides are both, are 2 of those measures. LDL cholesterol is not one of those measures. So, it all starts to make sense. But again, we don't have medications that effectively modulate HDL cholesterol or triglycerides. And so therefore we have come to focus more on LDL cholesterol. And as I said, the results of that are becoming very obvious. We are not making a meaningful impact in the prevention of heart disease with that strategy.
Now, how about the role of inflammation in heart disease? We hear about brushing our teeth not brushing our teeth as a risk factor for heart disease. And how do you integrate that into your practice, or how do you view inflammation in the whole picture of heart disease and metabolic disease?
Yeah, ultimately, I think inflammation, first of all, is very strongly associated with metabolic health. We know that people who are metabolically unhealthy have more inflammation in their body. But outside of metabolic health, there are some unique things that sort of cause inflammation. And really what this comes down to is damage to the blood vessels. So, in my mind, the way we should be viewing this process is something damages the blood vessels of the heart. And then cholesterol, LDL cholesterol, is part of the repair mechanism. It's basically, you damage your wall and then you take the spackle to, patch up the wall. But if you keep doing that, pretty soon you got a sort of, this big patch of spackle that's sticking out from the wall. And that's essentially what's happening inside the blood vessels of our heart. But, you know, the way to prevent that process isn't by getting rid of all the spackle, because then you still have the hole in your wall. The way to do it is not put the hole in your wall in the first place. And the things that damage our blood vessels are inflammation, you know, specifically from smoking, from high blood sugar levels on a, you know, repeated or a constant basis. And then, you know, high blood pressure, which is basically a side effect of poor metabolic health. These are the things that really, you know, set the process off. So if we can go back and start focusing on preventing the damage in the first place, then the cholesterol part of it, the LDL cholesterol part of it becomes, you know, very small and maybe even meaningless.
So really, statins are not that valuable in your opinion for this, correct?
Correct. I think they play a role. You know, I'm not saying that no one should be on statins, but I think they're very much overused. And again, you know, it's interesting when you go back to the cholesterol guidelines, the management for the, you know, the guidelines from all the official organizations, the American Heart Association, and you know, regarding the management of hypercholesterolemia, lifestyle intervention is always in there before statins. It's just we skip that step. No one pays attention to it. And what they, you know, the usual, you know, response to that is, oh, you know, patients don't follow it, or, you know, they don't follow the advice on lifestyle, so we have to go to the statins. And what I, you know, push back is that patients will follow advice that works. Unfortunately, most of the advice we've given around lifestyle, again, going back to the food pyramid, the USDA guidelines, low-fat diets, that advice doesn't work. So patients don't follow it. It didn't work for me personally. And, you know, so I stopped following it. But when we find what works, and again, I think, you know, we'll get into this a little bit more, but focusing on metabolic health via lifestyle, that works. It's worked for me personally. It's worked for, you know, many of the patients I work with now. And, you know, if you sit down with a patient and you say, listen, I can start you on a medication. You're going to need to be on this medication for the rest of your life. We don't know all of the effects that come from being on the medication the rest of your life. And despite putting you on that medication for the rest of your life, you're still going to have a pretty good chance of developing, you know, the end result, heart disease or something else. Or we can change your lifestyle, change what you eat, you know, and this is what works. 99% of the patients are going to take the lifestyle change, you know, if they are offered a lifestyle change that works. But we don't even do that anymore. You know, in the past, we offered lifestyle changes that didn't work. The patients didn't follow it. And then we as physicians stopped offering the advice and just went straight to the medication. And I think we need to kind of get back and reset and say, let's find the lifestyle interventions that work, and let's start offering those first before we go to the medication.
Yeah, that's such a good point about lifestyle. It's almost as if the notion of lifestyle modification has gotten a bad name, just as you say, because it doesn't work. And anytime you mention lifestyle, people sort of shrug their shoulders and, you know, walk away. But if we do the right lifestyle changes, it can be life-changing and transforming, as we're seeing. Going back to the coronary arteries and blood vessels, do you find CT coronary artery calcium scores to be valuable in managing your patients?
Yes, so I use CAC scans, coronary artery calcium scans, frequently with my patients. I think they're one of the best tools we have available to us. Again, you know, when you look at blood markers, whatever blood markers you're looking at, whether it's your LDL or, you know, we talked about triglycerides and HDL, you know, these are still just trying to predict risk. But we have a way of actually measuring disease directly. And the coronary artery calcium scan does that. And it's, you know, obviously, as you know, it's a fairly inexpensive, non-invasive, test. You don't even need an IV for it. It's very low dose radiation. It's online, with a chest X-ray. And it's quick, and it can be done inexpensively, and it actually shows, do you have disease in your arteries or not? And again, it is a much better predictor of risk than, any of our blood markers. So anyone with a CAC score of 0 has a 10-year risk of developing, a cardiac event of 1 to 2%, depending on their age. So if we have that test, which does a much better job of predicting risk than the blood markers, again, you start to ask, why don't we use that more frequently? And I think, again, you have to go back to, it would end up with a lot less people taking the medications to lower cholesterol.
Yeah, so if a patient has a CT coronary calcium score, and it is elevated, say it's above 100 or so, how do you view follow-up scans to manage their response to it? I know Ivor Cummins is a big proponent of this and following them up. Do you like to see the calcium actually, the number getting smaller, or do you just want to see a slowing of progression? What's your view on that?
Yeah, so I'm a big fan of Ivor's work, and we do know, again, from the data that if you slow the progression 10% a year, essentially, that kind of puts you back into a low risk group. So that's always the goal I talk about with my patients. We don't have good data yet on reversal and lowering CAC scores. There's been some scattered reports of it with various interventions, all lifestyle focused, by the way, that have shown those reversals. But, I don't think it's a reasonable expectation quite yet. I just tell my patients that our goal is to stop the progression. And if, we can get, a year and then 2 years with, very little to no progression, that puts you back into the low risk group. And again, I think the way to do that is with a lifestyle intervention that's focused on metabolic health.
Yeah. So now metabolic health, it seems so fundamental to heart disease. And as we'll see later, many other diseases. What exactly is metabolic health, and how do patients achieve this?
Yeah, so as with everything, you have to be able to measure it and define it, and then you can work on improving it. So the official, definition of metabolic health has 5 parameters, and I think that these are essential numbers that every patient needs to know, if they're truly care about their health. So the first measurement is waist circumference. And importantly, this is not your pant size, but this is, the circumference of your waist, right around the level of your belly button. Just take a tape measure. And if you're a woman, your goal is for that to be under 35 inches. If you're a man, it's for it to be under 40 inches. I tell people, an even simpler way to go about it is you just want it to be less than half of your height. But the official measurements are 35 and 40 inches for women and men. Measurement number 2 is your blood pressure. And you need your top number, your systolic blood pressure, to be less than 130. You need your bottom number, your diastolic blood pressure, to be less than 85. And that is without being on blood pressure medication. If you're on blood pressure medication, you've already failed that measure. And then the other 3 are all lab tests. So you'll have to go get a blood draw. Your fasting blood glucose level, and the goal there is for it to be under 100, again, without being on any, blood glucose lowering medications. And then your HDL cholesterol, for women, you want that to be above 50. For men, you want that to be above 40. And finally, your triglyceride level, you want that to be under 150. So those are the 5 measures of metabolic health. And more important than the numbers themselves, I think a great starting point for most people is just finding out those 5 pieces of information. If you take the measurement of your waist, go get your blood pressure checked, either at your doctor or, at the grocery store or the pharmacy. There are blood pressure cuffs available these days, those little kiosks, and then go get those basic blood works done to, find the other three numbers. That's a great starting point. And if anyone, doesn't remember that or wants some help with that, I actually have a tool on my website. If you go to ifixhearts.co, it will take you right into the metabolic health calculator, and it will give you your score. 88% of the adults in the United States, as of the data from 2016, did not meet all 5 criteria of those. So the flip side of that is only 12% of the adults in the United States, as of a few years ago, were metabolically healthy. And I think that should be a very scary number to everyone involved in medicine. And yet we don't talk about it. Most doctors don't talk to you about metabolic health for some reason.
Wow. Yes, that is a dramatic number, and it underscores the importance of not trusting normal, or not seeking normal lab values as your goal, but rather seeking optimum lab values. Because if 80% of people are metabolically unhealthy, then the normal lab may even be may include some abnormal people in that range
Exactly.
as well. That's really striking. What about other lab tests do you use to look at metabolic health? For example, insulin.
Yeah, so
insulin.
I do tend to go beyond that with my patients and do an even deeper dive. The fasting insulin level, I think, is a great, is another lab test that's very, underutilized. And the reason that the fasting insulin is so interesting and important is that we know that the fasting insulin levels will rise up to a decade before some of these other metrics will start to go awry. So again, we can get an early predictor, that you're on your way to poor metabolic health, even though you might not be there yet, by looking at the fasting insulin level. Another marker that I think is a very good reflection on metabolic health is vitamin D levels. We hear a lot about vitamin D. We hear a lot about, the involvement of getting sunlight. And, more recently, it's become a hot topic around COVID, because the data around COVID showed that if you had a low vitamin D level, you were at more risk from COVID. And again, I think that just reflects poor underlying metabolic health. What I see, in the patients I work with, both on the heart surgery side of my, practice and my metabolic health practice, is that patients who are metabolically unhealthy have low vitamin D levels. And I think, there's a little bit of influence of how much sunlight you get, but it's mostly your metabolic health that's, influencing your vitamin D levels. And that makes sense, because vitamin D is actually a hormone. As we know, it's not really a vitamin. And your body needs to, synthesize it, needs to make it. And metabolic health really reflects your body's ability to, carry out the functions that it's supposed to be doing well. So processing the food you eat, building and, maintaining muscle, repairing tissues, making hormones, all of this stuff is metabolic health. So it makes sense that if you're not metabolically healthy, you're not going to make, the hormones that you need in proper levels. And vitamin D is, one of the key markers of that.
Yes, that's such an important point, that although it's useful to check the 5 markers for metabolic syndrome, it's possible to be metabolically unhealthy and still have normal markers for metabolic syndrome. In other words, a normal fasting glucose, but an abnormal fasting insulin, like you say, could predate that by 10 years. And also that you don't have to be obese to be metabolically unhealthy. You can be a normal weight, and things like vitamin D need to be checked as well.
Yeah, that's a very key, point of information as well, is that, obesity isn't the same thing as poor metabolic health. People who are obese are more likely to be metabolically unhealthy, but there are a number of, there are people who are overweight and obese who are metabolically healthy. And the flip side is that there are many people who are not overweight or obese who are metabolically unhealthy. And this is the, in medicine, we call them the TOFIs, the thin on outside, fat on the inside. Being lean does not protect you from being metabolically unhealthy. And in fact, there's some examples where, essentially the ability to get overweight, the ability to put on subcutaneous fat, as opposed to visceral fat, is somewhat protective against, metabolic syndrome and metabolic damage. Not being overtly overweight or obese does not guarantee that you are metabolically healthy. And again, that's why you need to go get these measures checked.
Yeah, this is such an important concept. Back when I went to medical school, metabolic health really wasn't on the radar, and instead we focused on things like diabetes, heart disease, stroke, cancer, dementia as the main diseases that we face. But now the thinking has really changed about their relationship to metabolic disease.
Yeah, I think it's starting to change. I think in the mainstream, mainstream medicine still very much focuses on those diseases and, not the common, root cause of those diseases, which is poor metabolic health. So when we look at the reasons that people die, the top 10 causes of death, or, recently the 2020 data came out and we had an 11th, top cause of death because COVID was in there. But when you look at those, 7 out of the top 10 causes of death in the United States, and the data is much the same for, the rest of the world, are, 7 out of the 10 causes are clearly related to poor metabolic health. So heart disease, the #1 killer, has been for 30 plus years, is clearly related to poor metabolic health, as we discussed earlier. Cancer is #2, and many forms of cancer have been linked to poor metabolic health. Not all, but many forms of cancer are related to poor metabolic health. #3 on the list this past year was COVID, and the data around COVID is very clear. Being metabolically unhealthy made you 90% more likely to get COVID if you were exposed to it, get sick with COVID, and 90% more likely to suffer, severe complications like being intubated or dying, or being in the hospital from COVID. COVID, I have been talking about for a long time, and a few others have been, that COVID is a pandemic of poor metabolic health. And yet none of the public health, discussion around COVID, is on metabolic health. Not one public official has come out and said, if you get metabolically healthy, if you eat a little better, you start exercising a little bit more, you can significantly reduce your risk of COVID. That just has not been part of the discussion. And then as you go down the list, the things you mentioned, stroke, diabetes, Alzheimer's disease, emphysema and chronic obstructive pulmonary disease, although that's related to smoking. Again, it's also very, it's an inflammatory disease of the lungs, essentially. And it is, there are some clear relations to metabolic health there, and you just keep marching down the list and you end up, the only ones that can't be clearly attributed to metabolic health are basically accidents, trauma, and suicide. Although even suicide, I push back on a little bit because there is data showing that mental health is related to metabolic health. And Chris Palmer, he's a psychiatrist from Harvard, has spoken and published extensively on his experience treating severe mental health disorders with metabolic health improvement. So even you might be able to say that 8 of the 10 causes are related to poor metabolic health.
Yeah, metabolic health is truly foundational to the majority of the diseases that we face. So I'd love to hear about Ovadia Health and what you're doing to help patients with their metabolic health.
Sure. So Ovadia Heart Health is a telemedicine practice that I launched last year, and I work with people to prevent, heart disease and other chronic diseases. I work with them to optimize metabolic health. The patients that come to me, first step is kind of, a little bit what we went through, which is getting a very good assessment of where they're at in terms of their metabolic health. What diseases are they at risk for? And then what can we start to do to improve their metabolic health? And, my almost singular focus is on metabolic health. And what I tell people, because the patients that come to me oftentimes come to me saying, I want to lose weight, or I want to, I'm worried about heart disease, or I have heart disease and I want to improve that. And I try to, oftentimes reframe it to, you want to improve your metabolic health, and all those other things are going to be side effects of getting metabolically healthy. You are going to lose the weight. You are going to lower your risk of heart disease and other chronic diseases. But, we need to be focused on the proper sort of root cause issue, which is metabolic health. And so I work with patients via telemedicine. I see patients from all over the country, and we, mostly use dietary and lifestyle interventions to improve their metabolic health. And it achieves great success. The patients are happy. I oftentimes hear, this is the first time I've ever heard about this. And this is the first time that, physicians have given me, useful interventions that I can actually stick with, and, and they work. And once they work, the patients want to stick with them.
So patients can join this practice from really anywhere in the world. They don't need to travel to Florida or a certain location, correct? They can do it all through telemedicine?
Yes, I do everything via telemedicine, all online, and patients can be anywhere, certainly throughout the United States and pretty much anywhere in the world at this point. And that's one of the miracles of technology.
Yes. What kind of response have you seen in some of your patients?
Yeah. So, a great example, I have he's actually a nurse anesthetist that I started working with, about a year ago. He was one of my earlier patients, and he had, kind of typical story, mid 40s, early 50s. The gradual creep in weight, just, not enough energy to play with his kids and get through, demanding work day. And we started working on these metabolic health issues. And within 4 months, he was able to put on his uniform that he wore during basic training when he was 18 years old. And that was the first time in 30 years he was able to put that on. But more importantly, again, that's, like I said, the weight loss is the side effect. More importantly, he was able to, he had more energy. He was sharper, more focused at work. He was able to keep up with his son better. And he just, felt much better overall. That's a good example. Other patients that come to me, it is not unusual that within, a fairly short period of time, 30 to 60 days, we are getting them off their blood pressure medications. We are getting them off their diabetes medications. And then obviously, a large focus of the practice is on heart disease. And we're starting to see, those patients, like I talked about, who had an elevated CAC score, and, we're at the 1 year point and their scores are staying stable, which is exactly what we're looking for. Those are some of the common issues I deal with. And then, other people come to me that they're hesitant, they're worried about their risk of heart disease based on sort of the traditional measurements and the discussions they've had with physicians. They're a little hesitant to start statins. And so, what do we do with those patients? And that's when I do the real deep dive on heart disease with them. We do the CAC score. We do the advanced lipid testing beyond the basic cholesterol panels. And we really talk about what are what is your risk for heart disease, and are statins going to help, lower that risk significantly? And sometimes the answer is yes, and it makes sense. And many times the answer is no. And, we focus on the metabolic health improvement, and, they significantly lower their risk for heart disease without the medications.
Wow, that's beautiful. Well, in the last few minutes, as an expert in heart disease and lifestyle modifications for metabolic disease, perhaps you could share with us what personal choices you've made in your own lifestyle.
Sure. So, as I mentioned, after hearing Gary Taubes talk, I went, kind of low carb, low sugar at first, eliminated sugar, and then kind of got into low carb. And I went through, what I would call traditional keto. And ultimately, I ended up, basically sort of at the, carnivore end of things. Although, I'm not strictly carnivore, but, at my basic principles, my guiding principles for, the way I eat whole real food, and most of that is animal products. And that has worked great for me. I'm now 5 years in. I've, lost and maintained a weight loss of over 100 pounds. As I said, I reversed my, pre-diabetes. I'm at very low risk of heart disease. I've gotten the CHD score, which is 0, despite my elevated LDL cholesterol level. And it's, as I said, as I talked about with some of my patients, it's the most important thing is I'm able to keep up with my children. I'm not tired. I maintain I work as a cardiac surgeon. I maintain my telemedicine practice. Just finishing up writing the book, launching the podcast, all of that stuff. Obviously, very busy days. And I just find myself with, essentially unlimited energy, and truly feel better than I have ever felt in my life. I wear smaller pants and shirts than I did in high school. And like I said, I maintain this effortlessly. I do not feel, I don't do the dieting thing that I feel restricted. I love the food I eat. I eat when I'm hungry. I eat until I'm full. And, I really, in the end, I think and I worry a lot less about food today than I ever did in my life. So it's not a struggle to maintain this. And I think that's the bottom line. When we feed our bodies nutritious food with the goal of keeping our bodies healthy, our bodies respond to that, and as opposed to fighting our bodies, which is sort of what, traditional dieting does. So
yeah. That's such a powerful concept. The food choices you've made are not really a diet, but it's rather a lifestyle, and it's not something that you're going to do for 6 weeks and then get off of it, but it's just a way of being.
Yeah, exactly. And I think that's a very important part of it, is that mindset. And then the other things that come into play: exercise, stress reduction, getting out in the sun. Those types of things are all important as well. But I think diet, I think what you eat is the primary determinant of metabolic health. And, so that's probably 90% of it. In terms of exercise, my goal, again, and you look at the data around longevity, the number one predictor of living a healthy long life is maintaining muscle mass as we age. So I am a very big fan of resistance exercises. I am also very time constrained, so I'm a fan of efficient resistance exercises. And so for me, I end up doing 3 to 4 sessions a week, about 20 minutes. I use like a resistance band setup. And, my goal there is to, maintain my muscle mass as I age. And I think the data supports that, that's a very good predictor of both, quantity of life, but I think more important is quality of life. Again, I think most people don't want to necessarily live longer if they're not going to be healthy for, a major, portion towards the end of their life. I think building muscle is the way to both live longer and have a higher quality of life, during those, ending years.
Yeah, it's nice to be able to actually pick up your grandchildren and lift them up like
Yeah,
that.
exactly.
As far as your nutrition, do you practice any sort of time restricted feeding or intermittent fasting, any of those strategies?
Yeah, so I am a big fan of intermittent fasting, although again, I don't really do it intentionally, just because of the way I eat, because I eat such nutritionally dense foods, I'm just not hungry that often. So I end up eating, usually twice a day, and it's usually within about probably a 6-hour window or so. So it ends up being sort of an 18-6 intermittent fasting. But again, when I start working with my patients, I don't tell them, you should intermittent fast, 16-8 or 18-6 or 24, whatever it is. I tell them, eat whole real food that's nutritionally dense. And over time, you're just going to be hungry a lot less often, so you'll start fasting. And so I think fasting is a very useful tool, but it's usually not the first tool. The first tool is making sure you're eating the right foods, and then you're just naturally going to eat them less often. So another one of my guiding principles is, eat in a way that makes you hungry less often. And so that works out well for me.
That's a great concept. So how can people follow you, Phil, on social media and see what you're doing? They want to know about the upcoming podcast as well as the book coming in November.
Yep, sure thing. So most active on Twitter. I'm iFixHearts there at iFixHearts. And then, like I said, you can go to ifixhearts.co, and that will take you to it will take you to the metabolic health quiz. First and foremost, determine if you're metabolically healthy. And from there, you can sign up to be on my newsletter. You can get the information about joining my practice. But the most important thing that I want people to do is figure out if you're metabolically healthy or not. So ifixhearts.co, figure out if you're metabolically healthy, and then take it from there.
Thank you so much, Phil, for spending an hour with us and sharing your knowledge about the great work you do.
Yes, and thank you for putting this together. I think this seminar series is going to be a great asset to people. So thank you for pulling this all together to get this done.
Great. Well, we're definitely going to stay in touch, and can't wait to see the book and the podcast and all the other great things you're doing.
All right. Thank you.
Note: this is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have. Never disregard professional medical advice or delay in seeking of it because of something you have seen here. If you find this to be of value of you, please hit that like button and subscribe to support the work we do on this channel. Also, we take your suggestions and advice very seriously. Please let us know what you'd like to see on this channel. Thanks for watching, and we'll hope to see you next time.